celebration, if not a long-awaited occasion. Um, my name is Durham Wong Rieger, and I am chair of the Council for Rare Diseases International. And we're bringing this to you on behalf of both RDI and our partner organization, UHC. We're really here to talk about the universal health coverage because tomorrow is in fact the anniversary of Universal Health Coverage Day, to talk about addressing rare diseases through UHC. And those of you who have been part of our journey will realize why we say this is such an auspicious occasion, why this is truly a major celebration, even if we have to do it, all of us virtually. I think as we go through today, you will realize what an amazing year this has been for rare diseases and for UHC, despite the fact that we're all also dealing with the coronavirus, with COVID. So for today, we've got a fairly packed agenda. We're going to have a number of speakers. We'll have a number of videos for you and some really special messages for us as a community. So first, we're going to have a video and then talk about why we should be addressing rare diseases as part of universal health coverage. And that will come from Jan LeCamp, who obviously is really a leader in all of what we're doing in terms of UHC right now. We're going to have an opportunity to talk about how UHC is being implemented in other regions, and especially we'll bring you two perspectives, one from the Asia Pacific region and one from Africa. So I think that will be a really, sort of opening in terms of what is taking place, as we say, despite the fact that we're also being very, very much sidetracked by COVID. And then we'll have an opportunity to have you to share your stories, to share your, hopefully some of your triumphs, but also maybe some of the challenges that you're experiencing around UHC during this time. We're then going to have the introduction of the toolkit, which hopefully all of you have had. All of you have had the opportunity to at least take a look at, to be able to use some of the elements of it, if not fully. The Universal Health Coverage for Rare Diseases Toolkit, which has been put together by our colleagues between RDI and UHC, and we'll give you three examples of how that is being done by David Pena at Wicamexer in Mexico, Carita Akrom, who is going to talk with us from the Finnish Network for Rare Diseases, and then Margaret Hughes is going to talk about it from the point of view of one of the international patient alliances. So this will be a great opportunity to hear how certainly the various groups around Prader-Willi are using the toolkit, as well as the alliance as a whole. And then we're going to have more opportunities for you to engage in dialogues with us. And we'll end with a very strong message from certainly a real friend to UHC from the World Health Organization, Rudiger Craig. So without much delay, I think we'll move right into the program because there is a great deal. And we'll start with Kalani, who's going to give us a little bit of a reminder, though hopefully all of us are so very familiar with Zoom that this is not something we have to be told on, but some of the special features that we're going to be using for these 2 hours. Kalani, if you don't mind.
Thank you so much, Duran. So if you have any questions anytime during the discussion, please just type them in the Q&A box. If anything technical happens, you have a glitch, something happens in the call, just write to the technical host using the chat. If you want to ask a question and have your voice heard, just raise your hand and we'll liberate your mic for you. And if you just want to chat to us at any time, just write any comments in the chat and Clara will address all your questions in the Q&A session. Thank you so much, Duran.
We'll now launch the video.
Yes, I think we're going to launch into the video first.
Yes.
This is Nina and her family. It is a very precious moment for them. They have had a long journey to get here, all together, healthy and happy. When she was pregnant, Nina's mother had a difficult and complicated pregnancy, but Nina's father was able to rush her to the clinic just in time, when she had dangerously high blood pressure. Nina's older brother was diagnosed as HIV positive. Her grandfather had a stroke last year, and Nina's grandmother is finally being treated for tuberculosis after months of painful coughing. Like many other families, Nina's family also has had to deal with a lot of illness. They are very fortunate though. There is a health clinic a short distance from where they live, and they can access skilled healthcare providers and services that they can afford. In the country where Nina lives, people voted for country leaders who are committed to achieving universal health coverage by 2030. Through a progressive system, wealthier people contribute more money, and the government is able to provide an essential, affordable package of health services to all people, leaving no one behind, regardless of income, health condition, background, or where they live. So what looks like a simple meal is really a very special occasion for Nina's family. They had a long road to recovery, but never had to choose between getting healthy and putting healthy food on the table. And this sets them apart from many people around the world who can't afford or don't have access to essential, quality health services. Every family, everyone deserves universal health coverage. Let's work together towards good health and well-being for all.
Perfect. So thank you very much for the video. It really hopefully provides for you that snapshot of why universal health coverage. But now to build on that, we're going to ask Jan Lecomte, who is the Chief Officer for UHC and also, of course, on the Board of Directors for Rare Diseases International, and has been a huge champion in terms of UHC and rare diseases, to really talk to us about the importance of having rare diseases as a part of UHC, specifically in the declaration, but beyond that, of course, in each of the countries. Jan?
Thank you very much, Duran, and really a pleasure to be with all of you online. We should celebrate how lucky we are to live in digital time. Imagine the same pandemic and we cannot even connect as we do today. It's great. Yes, so my pleasure to say why rare diseases should be addressed as part of UHC, but also how to use the UHC in our respective work. There is first a global momentum towards universal coverage. It comes from the Sustainable Development Goals of 2030 of the United Nations and of all member states. And this sentence, which captures so much rare diseases, leave no one behind, which we are playing again and again in the UN system to say, don't leave us behind. And the UN adopted what's called the UN Political Declaration on Universal Health Coverage last year in September 2019. And that was a big day. It's probably one of the biggest milestones during these 15 years of Sustainable Development Goals in the area of health. That's the strongest new commitment that member states are making. This is what it represents. And that's why it's in New York, where everything is political in New York, UN General Assembly. And it's a health text, but for political reason and with political impact. This text explicitly includes rare disease in the scope of universal health coverage, and I will come back to that, in order to recognize the need to strengthen efforts to address the needs of people living with rare disease, but also, which is in Article 34, but there is other relevant articles throughout the text to which we can really relate in our advocacy action. More recently, last week, the United Nations General Assembly adopted in a special session COVID-19 different commitment and renewed its commitment towards universal health coverage in the context of the pandemic. And tomorrow is the Universal Health Coverage Day of 2020, Health for All, Protect Everyone. That's the theme of this World Day for tomorrow. So what has been the role of RDI and our members in this and the community at large in this period toward the adoption of universal health coverage? First, RDI raised awareness to specific countries in charge of this political dossier in the General Assembly, and we participated to the launch of the group of Friends of Universal Health Coverage. That was in 2008, and it was Duran who represented us all there with the ambassadors of many countries from the UN system. And then we had many bilateral meetings with the permanent missions to explain again and again why rare disease should be part of the universal health coverage. And that was not an easy battle, because with just the new kids on the block, the major topics like chronic communicable diseases, non-communicable diseases, and disabilities in general. So all that kind of bigger movement, and well, where there is a lot of evidence to establish the cause at the global level in the last decades, are much more positioned than we were. But we were able to be mentioned there in a satisfactory way. And we substantiated all our position with a comprehensive position paper on universal health coverage, which you can find on the website. It's here on the slide. And then we joined, after that, the Universal Health Coverage 2030, which is a consortium, let's say, of different NGOs and private organizations and public institutions. And the secretariat is led by WHO and the World Bank. So for us, that's part of the implementation, to be part of this movement, to follow the different tools and link to other legislations, etc. More specifically, we organized a high-level event on the occasion of Rare Disease Day 2019 at the UN headquarters, together with the NGO Committee for Rare Diseases, UHC and RDI, to ask for the inclusion of rare disease into this UN political declaration. And that was then February. And after that, rare diseases were included in the state commitment synthesis report, which was after the adoption, but they have a report to do, and there is a commitment on universal health coverage with regular reports, and rare diseases are included into it. This year, what we want to do is to develop tools that we will see in a moment, but also to make a link between this Rare Disease Day 2020 and 21 with a call to equity with these days on universal health coverage on the 12th of December. So the time is now for the implementation of the universal health coverage, and you have this very nice animation. Thank you to the team for that. It's very elegant. And this is what has been developed, is that since October, we launched the tools to advance the implementation of the universal health coverage for the parts of rare diseases. And for that, we developed a toolkit which has these 4 elements that you see here. The template letter for national policymakers, so you can really use it to write to your national policymakers. Obviously, it's a template, so you need to adjust it to your context, to contextualize your ask. Then you have fact sheets and policy recommendation, which can help you to substantiate your letter, but also to articulate what you are asking when you meet your top officials. And also briefing documents to help to do the exact same thing, but the fact sheet and policy recommendation, you can share them. The briefing documentations are for you. And you have also your social media pack to help you have elements prepared to disseminate in social media. With this action, what we want is to transform this UN political declaration on universal health coverage, which is an aspiration, right? It's not compelling to the member states. They have voted for it. It means that politically they want it as a global movement. Now, there is really a distance between that and doing it for real in your country, and then how far you do it. And that's what we want to focus on, is to transform it into an actual change locally in the inclusion of people living with a rare disease. So that's the beginning of the action. Now let me explain to go a bit deeper on why all that, and why universal health coverage is that so important for people living with rare disease. The ambition of universal health coverage is to ensure, again, it's an aspiration, ensures that all people everywhere in the world can access to quality essential health care without being exposed to financial hardship. That's the big thing, is that what universal healthcare address is not quality of care, is the coverage, is the fact that it doesn't increase the financial burden to the families. And there is 3 dimensions to that. One is the population. So which part of the population is covered? All the population, or only the one who are public servants or working in the army and in the police and in the healthcare services, for instance, or in education? Or is it progressively all the population, including in the private sector and including the one who are not working, and including the aged one, and including the disabled one, and including the one with a rare disease or any other disease? Then the second part of the services, does it cover the diagnostic? Is, for instance, a gene test being reimbursed, a biochemical test, the social support, the care, the physical therapy, the speech therapy, are they reimbursed or not? And then the cost and the out-pocket expense, because they can be reimbursed in part 2, which is the basket of care. But which part of it is being reimbursed? 100%, 80%, 10%? And we know how important that can be. And it's not only for the majority of the countries in the world with emerging economies and where you might have major differences between the capital city and the rest of the country. It's also true throughout the US. As to anyone with rare disease who have a treatment, how much they have to pay from their own pocket. Sometimes for innovative treatments, they have to sell their house, right? But take also in Europe, where a lot of the services for the management are not covered because they are not recognized by the system, because the evidence are not there to recognize the benefit. And sometimes common sense doesn't suffice. Now, why should we also care politically? It's because the fact we can already act, because rare diseases are included in the Universal Health Coverage Political Declaration, we can go to policymakers locally or regionally and say, hey guys, how do you include rare disease now in your strategy when you implement universal health coverage? Why don't you cover also this category of population? Why don't you cover these services? Why don't you consider increasing the reimbursement rate of this and this and this? So that works for any country in the world. And also, because we can do that, we're preparing the environment to do more with specific policies on rare diseases or the inclusion of rare diseases in their existing policies. Disability policy, social policy in general, hospital policy, etc. I could go on like that. Digital health policy. And between universal health coverage and the rare disease action, it is mutually reinforcing. Universal health coverage is obviously broader. It's for the world, for all the population. But for us, there is into universal health coverage also the leave no one behind. So how universal health coverage doesn't leave anyone behind. We can play that locally. And also to target these national policies on rare diseases, which is a moment where they are thinking about how to implement universal health coverage. That's the moment to draw attention to rare diseases without waiting potentially for a UN resolution on rare diseases later on. And these are the kind of services and population that, or services you can ask for the population. The visibility, the identification of people with rare disease in the healthcare system, the codification, that's one of the first level to recognize that the people with these rare diseases exist and can be counted. The access to accurate and timely diagnosis. If we are not diagnosed, obviously we don't have a rare disease, right? So we're not seen, we are invisible, we are not part of that population to be covered. So that are keys to enter in the discussion on population. The services, asking for the high quality healthcare, the multidiscipline healthcare in hospital, and the treatments, either generic treatments, well established, either innovative treatments, protected under IP, which may be more expensive, but also treatment off labels. It's part of it. When we say services, what is covered? And we know in some countries that the off-label may not be covered, for instance. The identification and accreditation of experts and expert centers, the social services and the research and part of it can be so included. And in terms of the out-pocket and financial hardship, the access to the affordable treatments, and the loss also, the last thing I didn't say is the loss of income also can be addressed here. The fact that one of the parents has to stop working to take care of a child, or one of the adult in the couple to take care of the parents if they are old people with a rare disease. And last slide is to make the link to this important ambition of Rare Disease International in its collaboration with WHO to create this collaborative global network for rare diseases, so that you already informed from previous communication and different regional meetings or previous global meetings of RDI. But there is a link here because from the fact of bringing attention in the healthcare system, having a major hospital linked to a university and a research center becoming part as a hub of the global network is also a way to draw the attention of the national authorities to rare diseases. And you can make a link to UHC. That can be part also of the way to implement UHC. You create a diagnostic center with a link and all that to the hospital hub. That's a way to provide the service that universal health coverage is inspiring. I stop here and I hand over back to Duran. Thank you.
Thank you so very much, Jan. I've heard you explain this many times, and it is not intuitive in terms of universal health coverage, and it certainly is not intuitive in terms of rare diseases and universal health coverage. But as you say, it is so very important, and they're so very much interrelated. And I think the other thing that comes across very clearly is, as you say, universal health coverage gives us as advocates the opportunity to really push for the inclusion of rare diseases, especially for countries where health services are just emerging, where universal health coverage is just coming in, and we make it clear you cannot wait until you've got everybody else covered before you come to rare diseases. We are here, it's part of the commitment. But I think the other thing that has happened very brilliantly, and I've been in a large number of seminars and forums, with regard to rare diseases and COVID, rare diseases with, health services. And we are doing things in the rare diseases community that are pushing the governments to say, yes, of course, we need to do that diagnosis. We need to continue in health services. We need to make sure that there are provisions for medicines. But they say it's not just for rare diseases. Of course, we would do that for all of our non-communicable diseases. So we push and we open the door for others as well, but we also innovate. And I think that's been really important. Here's some special things that we're learning in terms of how to do things by telehealth, how to do digital, how to actually support. And again, the things that we can do are also things that we can share with those that are not necessarily just rare diseases. So we say back, we contribute back, right? So, and I think that's the important thing. That was brilliant. Thank you so much, Jan, as always. So we're going to have a quick Q&A period, and I know that there are some questions that have come forth.
Question here, which is asking for the list of countries or government that have signed committed. So this one is pretty easy. It's unanimous. At the General Assembly, all countries have voted for it. So yeah. That's why I say that obviously it doesn't mean always a strong commitment, right? When you know the world, but the intention is there. But what we could provide you, I'm turning to Clara, is that I think there exists a list of the countries who were in the list of friends of UHC, but also the one who spoke at the General Assembly on the 23rd or 24th of September 2019. So I think we have that. So maybe we could share that, because that at least it signals that these ones are more committed.
Yes, definitely. I would take note of that.
And certainly there's differences in terms of how comprehensive they are in terms of what they're doing.
Yeah, of course. I see there's also a question in the Q&A from one of our colleagues, actually from the Rare Disease Day communications team. And he wants to get maybe a clear explanation on the difference between UHC and free public healthcare. So sometimes we've heard this question before. There's been a bit of confusion sometimes. People who tell us, oh, but healthcare is already free in my country. Why should I ask for UHC? And I think we've discussed this in the past, where UHC is taking a broader definition of healthcare systems. So maybe Jan, you want to develop?
Go ahead, Clara. I think you started. Go ahead.
Yes, no, I just want to say that universal health coverage is really beyond giving free healthcare. It's really about what we were saying about expanding the services available and the population that is covered. So it's really not just about the financial aspect of it. It's really about that universality and inclusion of populations and of services. So that's the difference, and where it's really useful for our community, because we can ask for these things that are not included at the moment. So that's how, in a simple way, I would say.
Exactly that.
But
Let's
there's
illustrate that with two elements. In some, you remember, in some countries, sometimes the priority is given to primary care, access to the frontline doctors for the maternal health, child health, and just the main immediate thing, but not the more sophisticated services. And that's exactly what Clara is saying, is that as rare disease, for instance, we want to have newborn screening. We want to have some gene test. Maybe we may want in some countries to ask for routine whole genome sequencing that's the kind of expansion of services we may ask, which today are not in the services. So it works to see for all the countries. But another example would be, if I take a country like France, when you have an epidermolysis bullosa, you still don't get well reimbursed for a lot of or out-of-pocket expenses or everything you have to buy at the pharmacy in terms of cream and bandages and all of that. That's about the out of the third pillar, the coverage of expenses. That works in every country.
And the WHO has actually got what we call indicators of universal health coverage that include everything from what is being offered to including the indicators in terms of the impact in terms of people. So I think we have looked at it in some of our workshops to say, here's what it says in general, how would that translate into rare diseases? So as you say, what tests are available, or even things like what are the, what's the percentage of diagnoses? So these are the kinds of things that are included as specific indicators of universal health coverage. As Jan says, services beyond just the fact that it is available, but also what are the kinds of services, what's the impact in terms of people, and then what are the outcomes that you can measure, everything from, live births, et cetera. So I think there are some great opportunities for us to really drill it down into rare diseases, but beyond just, as you say, the financial impact.
Exactly. And I think there's a very good point in the chat from Patricia Luki on the fact that the definition of health has also evolved, and it's not just about being cured, but as a well-being concept and living with your disease in the best possible way. So this is something as well to take into account, and it's UHC takes that into account as well.
Yeah. You have also interesting comment coming from our friends from Iran about the kind of challenges they have. So you see, that's a long walk between Iran voting for the political declaration and United States also, but because of the sanctions, this is, and because of the state of the country, these are the situation of the persons living with rare disease. So interesting. Thank you very much, colleagues, for doing that.
I think this is a lot of things that we want to cover in the second session, especially in the Q&A part of that session. So maybe we could, to not run over time, go to session 2, if you agree, Duran.
Yes, of course. So thank you very much. So nice to have such an engaging conversation. And Clara, maybe you can just introduce yourself. A lot of people know you, but it would be wonderful for people to know, because you play such a central role in terms of universal health coverage and our work with the UN.
Sorry, of course. Thank you, Duran. I am Clara Hervas, so I'm a Public Affairs Manager at RDI. So I have been working on the toolkit, the campaign for UHC, and other advocacy actions that we do at RDI. So feel free to email me, or if you have any questions on the material, or need anything else from us, I'm here to help. Thanks, Duran.
So I think we're going to start this with a poll, right? Connie, we're moving to a poll for the participants. This is not a quiz to see how well you listen to Jan, but it really is an opinion poll. There's no right answer to it.
So let's make sure everyone is still awake. What impact do you believe the UHC framework could have on your country over the next?
Shulani, there's an issue with your sound. Try to put your mic.
Is that better?
Yes.
Oh, that was even better for me there. What impact do you believe a UHC framework could have on your country over the next 10 years? More people with rare disease covered, better access for genetic screening, better access to timely diagnosis, better access to therapies, reduced out-of-pocket costs, enable access to expertise through regional and international collaborations. That's a bit of a nod to our global collaborative networks, I believe, with the WHO. UHC frameworks are not relevant to my country's context. Great, it is open.
just to say, you can click on various answers if you'd like. It's a multiple choice.
Okay, cool. We've got quite a few responses, so I'm going to end the call. Oh no, there's still more responses coming in. Okay, we're done. End poll. Dirhan, so I'll leave it up to you, but it seems as though the biggest response would be number 3, better access to timely diagnosis.
And that may speak to, I think, what the biggest need is, but also to the fact, I think everyone agrees, if you can't get to a diagnosis, nothing else really matters. And so that has been certainly a real focus. It also speaks to the fact that diagnosis, you know, certainly in terms of known rare diseases, right, should actually be universally available. There's no excuse for the known diseases, the known ways of diagnosis, for that not to become more and more available. It's becoming more routine. It's becoming available in batches. It's becoming, you know, much more cost effective. So I think that's really an important aspect. So I think people are kind of really hitting on to it. Better access to therapies, of course, follows right on the heel of the diagnosis, which I think is very true for all of us, regardless of how well therapies may be available. I mean, I think this a stunning fact that I see, you know, have seen over and over again is fewer than 1% of people who actually could qualify for a therapy for a rare disease actually get access to it. That's globally, of course, but in other countries, even developed countries, it's sometimes as few as 10% will actually get access to the therapy, even if it's available, it's been approved, and it's, you know, clinically the expertise is there. So we've got a long ways to go in terms of getting access to the therapies in a real way for people. And then obviously more people with rare diseases that are covered, better access to genetic screening, which follows with the diagnosis. So this is, I mean, this is obviously a global snapshot, and there are, you know, obviously huge variants. I want to know who's sitting out there saying UHC framers are not relevant to my national context. I need you to write to me afterwards, and we're going to have an actually one-on-one conversation. You either have a great explanation for this, which we all need to hear, or we need to really have an understanding of that. No, I'm only kidding. But hopefully nobody believes that none of the universal health coverage is relevant, but there may actually be something to that. So I say that a little bit in jest, but I am a little concerned, and we do hear it sometimes that, you know, why should we be working on universal health? Not because we've already got everything, but I see it as too remote. And that's why the explanations from people like Jan and Claire are so important. So great. Okay, so I think we're ready to move on. We run a tight agenda here, so we really want to give an opportunity. Any other quick comments? I want to see if there's someone in the chat that actually.
No, I was checking. I think we can move on to Ritu.
Oh, perfect. All right. So we're going to move to 2 regional presentations of somewhat briefly around what universal health coverage and rare diseases, both the activities, kind of accomplishments that have been taking place. My real pleasure to introduce really close colleague of mine who I've been seeing far too much of in the last few days, only because we've just had our regional conference.
Couldn't agree more.
But first of all, really congratulations, Ritu, for really 2 masterful days in terms of the APARDO conference and the ability to pull this off in this very crazy time. So kudos to you and to everyone that was there. Introduce Ritu Jain, who is the president of the Asia Pacific Alliance of Rare Disease Organizations. A brief update, a very challenging update, obviously, to talk about UHC across such a wide region.
Thank you, Dirhan. I'd like to just say a few words, not too much at this time, running close to 11 p.m. here. I think it's very difficult to comment on UHC for such a large region. In terms of WHO regions, there are 2 that we oversee here, Southeast Asia and Western Pacific. And I think generalizations are not only impossible, but also unfair. Certain countries in this part of the world, we'll just call it Asia Pacific for convenience, have done relatively better. Japan and Singapore rank very high, not only in the region, but globally actually, whereas others such as Taiwan, China, Hong Kong, South Korea, Australia, New Zealand perhaps, managed to deliver a very good quality of healthcare, while others such as India, Indonesia, Malaysia, Philippines have explicit universal health coverage policies and commitments, but fail to deliver on them in practice. So I hesitate to equate universal health coverage policies with good healthcare. I think in this part of the world, we need to examine healthcare or access to healthcare, especially for rare disease populations, as more targeted. So consider as an example, my own country, Singapore, which ranks 6th globally on the WHO health report, but it spends only 3% of its GDP on healthcare. Most of the cost of the healthcare is borne by the patients through a very complex mechanism of social security, savings, etc. So, but does it recognize rare diseases is the issue. In principle, it may not have a universal health coverage policy, but it delivers healthcare to the population. So the coverage is very robust. People are not impoverished because of payment for healthcare. But in terms of rare diseases, it recognizes only 4 rare diseases since 2018, relatively young rare disease policy. Other rare disease conditions go absolutely unrecognized, and patients can't even use their mandatory social savings, medical savings, to pay for out-of-hospital care, which is a given in most rare diseases, medicines, dressings, ointments, etc., as well as hospital doctor visits, out of hospital visits, as in non-hospitalization visits. So in order to assess UHC in the Asia Pacific, I would look at 3 main aspects of UHC for their relevance to rare diseases: the population, the services, and the costs that are covered. In terms of population in the APEC region, UHC policies certainly select very few rare diseases, and there is tremendous variation in what is even defined as a rare disease for the purpose of financial coverage of services and support. So can we do better? Certainly, there is huge ground to cover. In terms of services, even when there is coverage for rare diseases, focuses on hospitalization and to some extent medicines. Maybe there are outliers like Taiwan, you could have South Korea, Japan, but conditions on these lists, despite these conditions, there's a huge gap in provision for non-medical support and community-based care. So yes, there is still a lot of scope for these countries to do even better. In terms of financial coverage or costs for rare diseases, this is probably the weakest area for significant out-of-pocket expenses in most countries here. There are laudable examples, but insurance companies are seldom part of the conversation to consider services that may be eligible for coverage and include patients in rare diseases. So perhaps in the Asia Pacific region, we should be looking at countries that practice universal health coverage rather than those that have policies for universal health coverage, and whether this approach favors people living with rare diseases.
Ritu, that was absolutely a brilliant synopsis, and really very, very clear, but also, I think, helping us to understand, as you say, the disparity across the region, but also disparity even within a country and certainly among the conditions. So thank you very much. So we're doing well in many ways, but we certainly have a long, long way to go. So lots of work for us still. Thank you very much. So I'm going to turn over now to Ida, who is going to talk to us from Botswana Organization for Rare Diseases. Ida, over to you.
Your microphone is on mute, Ida. Let's see. There we go.
Yes. Thank you very much for the opportunity, and hello everyone. It has been a very long time since I've seen your faces physically, but thank you for this opportunity. When Hlawulani talked to me about this, I said, there isn't much to be said this side of the world. But basically, in terms of policies and frameworks, our policies and frameworks are basically more focused and more targeted on primary health care. And they are so much limited into looking into the cost. How costly is the intervention going to be, which we obviously know when it comes to a rare disease, you're definitely going to be thrown out of that basket. So in that aspect, we really have nothing, unless maybe by accident your rare disease happens to be covered or happens to be cheaper to manage, then you will be afforded the healthcare services that you do need. So our healthcare services, they are more basic, and when it comes to needing more specialized care, then you do struggle to get the specific care that is relevant to your condition. Our challenges towards accessing the orphan drugs or orphan medications, so far we do have challenges with regulation. Sometimes where we do have, we had opportunities through charitable programs. Sometimes it takes very long to get those permits to get our medicines through. We also, as we always say, we lack opportunities for clinical trials, because through those, sometimes when they see that these therapies do work, because they need to see them face to face that they are working, then it could be something that could encourage the policymakers to have a serious look at this. The costs, they always say those are prohibitive costs. The government or even the medical insurers, they will just say, no way, we can't do that. Even if you do have, like for example, in my case, my medical aid had a benefit portfolio that had money that could even cover my daughter's treatment. But they said, one, the condition is not in the list. Two, the treatment that you are taught of how effective it is. Delayed diagnosis or even its non-existence, because most of the time we have to refer out of continent. That is a challenge that we do face, because if you don't have a diagnosis, even if somebody has the treatment that you have or could offer it to you, then you are not going to be able to access it. Access to social services. Our social services, they are generalized. I remember I've had cases whereby patients needed simple things, like supplements that are specific to their conditions. And that medical aids or medical insurances would say, we don't cover supplements, without necessarily specifically addressing it as a specific need for that condition. And if you go to other social programs that are available from government, they would just take everything in a generalized manner, that from time to time we have to push them to say, when it comes to these conditions, it is different. You need to look at it differently. So you'd find that, yes, there are such programs that are available, but that doesn't mean that access is easier for rare disease patients. Out-of-pocket expenses. The only way to survive is to have all your money gone, or the only way for your child to survive is for you to have all your money gone, because government doesn't cover most of these things. When it comes to specialized services, which we most of the time need, so most of the time, tell this country, we go to South Africa, we bother them that side, but you only can do that by taking money out of your pocket. So it is a difficult situation. So for those that don't have medical aid, because majority of the people in this country, they don't have medical aid. So then that means that they are not getting the relevant care that they need, or the minimum of care that they need. What is the country doing that is better? We do have facilities that would need maybe to build more on capacity and to be more focused on rare diseases. That could help a lot to ensure that rare disease patients, you don't just say, I'm offering free healthcare, which my country prides itself with. But when my daughter, the only thing that she needs is an enzyme, and you have loads and loads of Panado, it means nothing to me because it doesn't specifically address the needs. So what is needed is specific interventions that address the peculiarities and specificities of rare diseases. Thank you.
Thank you so very much, Ida. I think providing that very realistic view, both in terms of the universal health coverage and the status there, but also the really challenges, as you say, for rare diseases within that. And also what you really do indicate is that this is almost on a disease by disease, case by case approach that one needs to take at times, because having just the overall statements of availability are not going to address the kind of specificities of individual cases. Really appreciate very much not only your presentation, but we know very much your continued work, not only on behalf of rare diseases, but overall for people in Botswana. So much thanks to you for sharing that. Okay, I think we're going to have some time to do a bit of a Q&A.
Yes. So if anyone wants to ask a question, please feel free to put it into the Q&A section. I also see there's a comment from Trudy, who I think pinpointed something that came from both presentations, the gap between practice and policy, which appears to be getting wider. And I think that this is something that we have seen. And thanks for putting that comment into the chat. If there's not other questions for now, there was also a question on in countries where there's already a struggle to get basic healthcare, is UHC meant to focus on common conditions then? I guess we will maybe all agree to say that they shouldn't, but if anyone would like to comment on that. Any of the speakers?
Maybe we can ask Ida. Ida, is the focus on common conditions and opening to rare diseases, or would you say in your country, in order to serve needs, one has to go in with a very targeted approach to say, this rare disease, this treatment, this is what you want, and maybe if you're successful there, it would open up to, other diseases and other treatments being made available. What would make the most sense in the environment that you're in?
Well, currently, because nobody is admitting that there is need to focus on rare diseases, the focus is still more on malaria, HIV, tuberculosis, and all those conditions. So it's like nobody knows they are rare diseases, even though they see them, even though you talk to them about them. It's something that they just brush off. So a decision, first and foremost, to say, we are responsible for this, and this is something that we need to focus on. Let's see how we can manage it, would be the first thing to do at the very beginning of anything else. So once that is done, there are other options that could help address this thing of saying costs. I don't believe it. I've worked for health. I know that there are drugs that are expensive, there are interventions that are expensive. And my country, regionally in the SADC region and through the AU, they have a pooling system that they use to address such expenses. And it reduces costs to do that. So it's only a matter of deciding that this needs to be done, and then you look at the actions that you need to do.
So Flaminia put in a question, does anyone have an example? I mean, I'm going to ask Ritu, because I know that we just recently came out of 2 days of conferences and what do we hear from other countries? Because we have a huge range of it. Were there some examples from some of the specific countries in terms of how they got rare diseases, not just on the agenda, but actually some services or treatments brought in place? Can you give us an example, Ritu?
I can think of Taiwan as 2 decades of consistent lobbying, as well as of Australia, actually, how they didn't give up, persistence, relentless persistence of trying to get more and more conditions included, and lobbying for a rare disease policy, really, that got more than, I would say, a universal health coverage policy, but fighting for inclusion of rare diseases in health policies. that led to success. At the same time, you have countries like Philippines, which do have a rare disease policy, but don't have the socioeconomic means, the budget for their implementation. So really, I think it's a bit of a balancing act between having the financial wherewithal in a country, insurance, private, government, collaboration, and having policies, the political will really to want to make a difference.
Yeah, and one of the things that struck me certainly from the Philippines and from Malaysia, when we asked kind of what was working, they said choose something that is successful. So in Malaysia, as we heard, it's again around a very restricted number of diseases like consumer storage diseases, get the governments to focus on that. In Philippines, it was metabolic diseases. So get them to focus on that. Choose something and work with it, and hopefully you can expand beyond it, get some successes. It's kind of what I was hearing.
Absolutely. In Singapore too, the government says, okay, let's have 4. It was 3. And then last year we got 1 more added. And we hope that little by little, we win an inch at a time and we get there.
Yeah. Kind of sad, eh?
It is, but that's what we live for.
Yes.
Okay. It's Tony. Can I just make a point that, of course, people with rare diseases also get common diseases. They get malaria, presumably, and so on. And sometimes that can provide, I think, an opening to get someone, a clinician or someone interested in the person who's now come for treatment with malaria, but who also happens to have a rare disease. And if you can get a clinician as an advocate on your side who takes an interest in that rare disease, that can be an opportunity for really using the common disease to get at the rare disease. I think that's a story we've heard occasionally in my field of Prader-Willi syndrome.
Thank you. And I know you're not suggesting that people go out and get malaria. I understand. That was not what you were trying to say, but I think you're very, very right. And it's also an opportunity, maybe what Edith says, to educate the clinician. Because a lot of times they don't know. So it's, unfortunately, I think it's just as Ritu said, sometimes it feels like inch by inch, but where are their openings and how do we make that kind of a case? And we'll hear more from you folks as well. We're really very excited in terms of what the Prader-Willi community has been able to do in terms of getting greater awareness. So yeah, I wonder, Claire, if we are, Swani, if we need to move on.
We still have about 10 minutes if anyone has.
Okay.
Yes, so if anyone has any other questions, there's one that just popped into the Q&A box. So it says, in low and middle income countries, most of the focus is on essential care, so maternal and child care, surgical care, not included, NCDs. So advocacy work such as this is critical, but ultimately it is up to each government to do this. Is RDI engaging with patient and family organizations in different countries to help them advocate? I think one of the main things we're doing is creating this sorts of tools. So the toolkit, so that the family and the patient organizations can use them and in their advocacy. We're of course open to hearing feedback on anything else that RDI could be doing that could help our members. So please always feel free to drop us a line around that. And maybe Duran, you have.
Yeah, I don't want to brag again, but I do think it's worth a brag to talk about.
May I add before you?
Yes, of course.
Yeah, I would say that RGI is doing a lot. It is through RGI now that we have a statement that addresses rare diseases at that level within the universal health coverage. And that is something that me alone in my country would not have achieved. And that weighty level, we get it by being part of the RGI. That helps, and even the engagements with the WHO. So I find that useful because coming together and doing that, it helps me to come with something that now I can use to address my needs at national level.
That's a huge statement, Ida, and so much appreciated. You know, one of the things we were trying to do is to actually talk about regional meetings and national meetings and how RDI can actually participate in those. We even have specific plans for how we would actually support organizations that are doing it, or regional organizations. It's just that with COVID this year, of course, everything kind of began to melt away, but that is a huge reminder. And that's such an amazing comment to make. I was just going to say very quickly again, not to just brag, as I say, back to Pardo, but I think having those regional meetings really does bring the opportunity to have, as you say, we have Philippines, Malaysia, Thailand in the same room as you know, Japan, Taiwan, and others that are doing a lot. And I think it's a great opportunity to really, you know, use RDI, but use its regional networks as well. But Ida, we hear you, and it's a huge reminder to us to also think about how can we go in there and be a much more of a presence, if in fact, as you say, being that presence also brings in those other levels of support. So thank you very much for that.
Yes, really. And we're having as well some questions in the, well, some comments and questions in the chat. I think one which is good, and Minia answered in the chat, but I think it's good that everyone hears, is that we should identify and share success stories for certain diseases. And that way we will be able to learn from other groups. And I think it's a good idea to bring as examples as well in our advocacy. So very good point.
And then this is why we're doing this conference, though. Remember, we've only had, you know, this for 1 year. You know, we haven't been at it for a long time yet. So we've just been, you know, having universal health coverage as a big umbrella, but also within that rare diseases. And I think the toolkit, as Clara says, is a huge asset for you. And maybe again, next year, we could have a great opportunity to share even more stories about how countries and different organizations are using it and being able to, you know, maybe even, you know, more specifically, Clara, think about some workshops, bringing people in on how we can share experiences. The same as I think the Rare Disease Day, there's now the very specific kind of workshops on how do you use social media, how do you get to the media, how do you get to your politicians, and maybe even some workshops around the toolkits would be useful.
Exactly. I think that's a part of our action plan for next year, and the way to continue the campaign, the UHC for Rare Disease campaign. As Jan had in his presentation, it's not because tomorrow is UHC Day that the campaign ends. The goal is really to continue over in next year, and it's all about that implementation, and that's going to take a long time. So we want to create these opportunities that, as Duran was saying, workshops, hear from you. We sent some questions over prior to this meeting that are things that we would love to hear from you, and you can always send those comments to us by email. So feel free.
Can I address this question from Salome? She asked, are there any experiences of using COVID context and this timing of healthcare being on all government's priority as an opportunity to advocate? And that's a brilliant question, because absolutely the answer is, and I will say one of the things I've been involved in over the last month is APEC, the Asia Pacific Economic Collaboration, has been hosting workshops with member states on COVID and rare diseases, and bringing in, last night with Malaysia, Hatijah was on a panel with me as well, with the Deputy Minister, the Minister of Public Health, all talking about COVID, but also in the context of rare diseases. It was a brilliant, you know, integration of the two themes. What are you doing on COVID, but then how does that have an implication for rare diseases? And it really forced the governments to also acknowledge, you know, the necessity of continuing to deal with common conditions, but also rare conditions, even as COVID was a priority for them. So I think there are some opportunities to do that much more deliberately. I also know that we have sat at some of the tables, in the NCD Alliance more recently, but also with the WHO, there are tables on COVID where we can show up as rare diseases and be a part of the conversation, right? It helps to raise the awareness, and more, I think, as people are dealing with COVID, and governments and health ministries are dealing with COVID, they're hearing back, as the report from RDI has shown strongly, we really will do great harm to public health. We do great harm to people if we do not continue to provide the services and special provisions for the needs of people with more common conditions, or in our case, talking about rare diseases. We go backwards, we have greater harm. So I think continue to bring that issue forward, not to say that we're against COVID, but that, by neglecting the common conditions, and by setting up the kind of barriers there are for access, that there's causing harm. So I think even in the next year, as we're dealing with COVID still, that is a great opportunity for us to and I think that's a great question. We need to show up in those COVID conversations, and we need to make our voices heard in those COVID conversations.
Definitely. Just as another comment, I wanted to say that also in a lot of the member states that we have meetings with are telling us, unless it's related to COVID, we're not ready for this discussion. So if you link it to that, at least you'll be able to get your foot in the door. And COVID is proving that there is a problem for vulnerable populations. Access to care has been disrupted. So that's the kind of arguments that you can also use to start those conversations and make sure that rare diseases stay relevant in these times. So thank you for that question, because it's important to stay within the context that we're living. It's true. So thanks for that. There was also a comment from Celia on the fact that, of course, UHC for rare diseases is an aspiration, and there's going to be different speeds for different countries. To be in the same speed would be an ideal. However, conditions in every country are different, sometimes very complicated. If anyone wants to comment on that, it's true. I think we need to be aware that every country is going to go at a different speed on this. We are aware. But unless any of the panelists have anything to say on that, I don't see more questions in the chat. So maybe last chance for anyone who would like to ask something, and otherwise we can move on to section 3.
Yes. Well, we'll still be here, so you can ask your questions in section 3 too. So don't feel pressured. I know sometimes it takes a while for people to formulate the question. So don't feel pressured, even if it's not, even if it comes up late and you say, I should have asked that before. It's okay. You can continue to participate. We will have lots of opportunities. Thank you very much. So we are going to then move into the next section, which really has to do with the case, the toolkit for universal health coverage for rare diseases, which was sent out. And we really were pleased in terms of people's response to it and the uptake on it. And we were going to present, we've asked 3 groups to actually present how they've been using the toolkit. So we'll start with, I think, Toto from Mexico, who's going to talk about it on behalf of MXer.
Thank you all. Thank you, Doreen. I would like just to add before my presentation that COVID is an opportunity. Let's not see it as a big trouble. I mean, I know it's a big problem, but let's see it as an opportunity for our representatives to see that even though it's a virus, it's also like a rare disease. It's also, I mean, it's not also. Rare diseases can attain everyone, so as COVID. And let me give you some numbers. Let me throw you some numbers. Mexico has currently 130 million of the population. So more or less 9 million people have had rare disease. So let me start with this. And can we have the slides, please? Okay, well, I'm an advocate for Gaucher disease, and I'm also head of social network in Femexer and Pide un Deseo. Next one, please. At Femexer and Pide un Deseo, Femexer is the Mexican Federation for Rare Diseases, and Pide un Deseo is my own ONG for Gaucher disease and then lysosomal diseases. Currently, yeah, as Clara was telling us and Jan, healthcare is something, and universal health coverage is another one. Mexico has already healthcare in many lysosomal diseases, in many rare diseases, but there's still not enough. Currently, our GDP for health is 2.5 So it should be at least 8 or 9, but we have to take step by step. Also, it's Mexico. A lot of other countries in the region of America, in South America, they have huge trouble. They don't even have healthcare. I know Iran. I know also not talking about Latin America, but also Africa and some parts of Asia. They also have different trouble. Not all of us are Europe. Not all of us are Canada or US. But currently, we've been working since 25 years ago, and we have over 70 different rare diseases organizations pushing together. It's great that the WHO and the UN are pushing together for the universal health coverage, because it will take all the eyes to this. It's very important that not only cancer, I mean, it's super important, not only diabetes, but also rare diseases should be in the mind of everyone. Next one, please. Well, as some of the questions, does Mexico have a framework policies for the UHC? And do these policies cover people living with a rare disease? As I already told you, yes, we have healthcare, but there's still not enough. We have lots of work to do. Since 3 past governments, Mexico has been stumbling to develop an UHC policies, work out via Seguro Popular. That's the name of the health insurance that it was for free. And now it has become INSABI, because we have, since 2 years ago, we have new government, and things are getting step by step really slow, and all the health eyes are on COVID. Right now, we are at the peak of the second pandemic, so it's really hard for us right now. Have you used the UHC to advocate for better coverage for rare diseases patients and families? Yes, of course. Since 1997, our main goal has been to treat all of these patients. We didn't want them to keep dying. It wasn't on our plans, and it's also step by step. What have been some challenges or barriers to your advocacy for rare diseases in Mexico? Definitely Mexican bureaucracy, on knowledge of the people in general, ignorance, negligence of also physicians, representatives, hospitals, institutions, who simply don't want to recognize that they're sick or they have a disease. So we're still fighting since many years ago. And the last one, have you used the UHC for rare diseases campaign materials to support your advocacy? Currently, we have a huge campaign for Access Salud, which is our main information and orientation, plus a free psychology program for rare diseases and their families. And also it's been really helpful to have the fact sheet that we've been sharing on all our webpage, on our social media, that in these times we just figured that it's super important. The letter template for the policies, we already have sent it to our representatives. And the briefcase, it's also really important that we push on that. Social media, it's been a great tool for us, and we will keep our work as it is. The next one, please. As I was telling you, Access Salud is the first and only registry for rare diseases in Mexico, and it's been developed to provide information, guide, and free psychology help for patients and relatives with a rare disease. We want to, I don't know the word right now, but we want to duplicate more or less the Access Salud program to the UHC program, and hopefully we will get to more people, to all those 9 million people with a rare disease in Mexico. The next one, please. And this is our Spanish fact sheet. Cobertura Universal en Salud. We will work for all rare diseases. UHC leaves no one behind. And that will be all. Thank you.
Thank you so very much, Toto. It's always amazing to hear your dedication and the work that you put in. So huge congratulations on everything that you continue to do. I've been watching you for so many years, so thank you very much, and for your contributions also to RDI. Okay, we will move on to, we'll have question time for Q&A after we've heard from all three of the groups. Now, a real pleasure to introduce the Finnish Network for Rare Diseases, Karita. I want to say Ackerblom, but you probably will do a lot better after you start. So thank you very much, and we'll hear from Karita.
Thank you. And you were really close. It's Karita Åkerblom. So it's a Swedish name. We have two languages here. So I am going to share this one slide I have. Do you now see it? Because I have a bit different view here. Just a minute.
We can see it.
Okay, that's fine. Now it's better. So we are not so many as people in Mexico. So just a minute, I have to rearrange a bit here so I can see my notes also. Sorry for this. Yes, thank you very much for being here today and to tell something about why we left in this campaign. And no, I'm sorry. Excuse. So we believe that the best way to support better health and social coverage for rare disease patients is the collaboration, both in international and national level. And we also wanted to remind the public that we are a part of bigger structures such as United Nations, RDI, UHC. And you can see here some figures about Finland and the map of Finland and the slide. We are only 5.5 million people here. And we have approximately 300,000 people living with the rare disease. And as you can see in the map, the country is divided into 5 areas, which are called specific catchment areas. In every area, there is a university hospital who is responsible for the whole area. And because of the special healthcare for rare diseases is centralized only in these 5 university hospitals, it sometimes means a lot of traveling for the patients, especially in the north of Finland. And you also all know that people with rare diseases have similar challenges everywhere. The lack of information and knowledge, limited research, misdiagnosis, delayed treatment. And because we are not so many here in Finland, the research is one of the problems here. And you probably also know that we have a free public health care here in Finland. And that was one of the challenges for us in taking part to this campaign, because it seems that we have no reason to ask for more, because we already have things much better here than in some other countries. And we even do have a national plan for rare diseases, which is produced by the Social and Health Ministry. And there is the fact, we are really proud of the fact that the plan is written by our own representative of Network, who was an equal member of the team, where were doctors and decision makers. And the plan consists of 3 main components. They are to increase knowledge and information about rare diseases, coordination of functions in the rare disease field, and what we consider the most, well, a very important part, to strengthen the involvement and empowerment of people with rare diseases. But even if we have this plan, that's only a piece of paper if the good intentions don't transform into practices. There's still much left to do to support the rare disease patients, not only here in Finland, but also worldwide. And at the same time, we wanted to remind that universal health coverage is a human right, and people with rare diseases need more attention in order to get a good everyday life. And the materials, you know that Finnish language differs a lot from English. We have very, very long words we can't use. So this here you have hyvä arki kuuluu kaikille, which means a good everyday life belongs to everybody. And that's where we have, so you see that we have been very creative in adapting and translating the materials that they should fit in our system and in our language. But the message and the idea are still very clear. It's the place you live in, your economic situation, or the rare disease you have. They mustn't affect on the healthcare you get. So far we have driven the campaign in social media and in our website. And even some of our member organizations have shared the posts. But we have an election coming on the spring, so we will use the letter template. We will have to adapt that as well, but I think we all know that it's good. We can say it's something bigger than just we two employees here who have tell you something, but this is worldwide. I guess I have now used my time. So if you have any questions, so please write them to the chat. Thank you.
Thank you so very much, Carita, and very much empathize with your comment that we already have healthcare. We already have a rare disease plan. So what else can we be asking for? But as we know, having something in principle and having something even in legislation is not the same as having it in practice. But sometimes it's harder. And I will say I spent one of the best holidays of my life in Finland. So we can talk about it in a little town called Vuokatti.
That's wonderful. Now in winter where there is some snow, we don't have snow here in Helsinki, sorry.
Really, thank you very much. And now we're going to get a slightly different flavor and have a presentation from the International Prader-Willi Syndrome Organization. I think it's a two-person presentation between Margrethe Hughes and Tony Holland.
Thank you, Durhan. Actually, I think I'm speaking today, though Tony can chip in if I'm saying anything wrong. By way of introduction, the International Prader-Willi Syndrome Organization acts as an umbrella body for 37 national PWS associations around the world, and it supports people in over 100 countries internationally. PWS is obviously a rare disorder. Various estimates suggest that it affects between 1 in 15,000 and 1 in 25,000 people born. It's characterized by a very wide range of characteristics, including things like low muscle tone, behavioral and psychiatric problems, physical problems, and something called hyperphagia, which means a relentless drive to eat. Oh, I'm sorry, I was supposed to share my screen. I apologize. 1 second. I don't know if you can see that now.
Not yet.
So Helwani gave me 5 questions and suggested that I speak to those, which I'm happy to do. So the first question related to how UHC frameworks or policies could be used to support better health and social coverage for people with rare diseases. So firstly, I would say that the UHC framework provides a coherent means of campaigning for equity for people with rare diseases. As Jan mentioned, now is the moment because commitments have been made, even though they are aspirational, and there is a date by which we can expect progress to have been made. Secondly, I would say that the UHC framework facilitates a shared campaign that can bring together different countries and different rare disease groups, thereby, of course, increasing our impact. And probably most importantly, however, I would say that the UHC framework provides a vision for how people with rare diseases could be integrated into health and social services. I would say perhaps that the framework normalizes the idea of people with rare diseases receiving healthcare and social services on an equitable and equal basis to others. And this is not, in many cases, what happens now. Of course, many people with rare diseases now are treated as somehow other or different and are only assisted if there's money left over or if somebody happens to take a particular interest in a particular disease. So the question relating to barriers that have arisen in terms of advocacy for PWS specifically, some of them are similar to many rare diseases. I would say the small numbers is clearly a challenge. The fact that people are geographically dispersed is also a challenge. And so too are various cultural factors, which I think Totu may have referred to also. There is sometimes a reluctance to admit that a family member has a particular disability, which of course will reduce the number of people who are available to advocate. Advocacy priorities in terms of PWS differ significantly in different parts of the world. In some countries, people can access early diagnosis. They can have the services of reference centres or multidisciplinary clinics. They can access growth hormone and other treatments. In other parts of the world, they may still be looking for diagnostic testing services for basic access to a doctor who knows something about the syndrome. So I think while advocacy is ongoing everywhere for PWS, the particular advocacy goals can differ. Self-advocacy is also quite difficult for people with PWS for many reasons, and similarly for their caregivers who may be overburdened with care needs. In terms of challenges of using UHC, I would say in our experience, there's relatively low awareness of the UHC campaign among rare disease organizations. I would say too that some organizations may have already committed their limited resources to other initiatives. So for example, I spoke this week to somebody who is very actively involved in seeking growth hormone treatment for people in her country, and that is their single and specific goal at this moment, and that is not linked to a bigger framework. And of course, the problem we're all familiar with, which is the difficulty getting key decision makers to take an interest in rare diseases. In terms of advocacy wins for Prader-Willi syndrome, I think growth hormone therapy is provided as a treatment in many countries, and this has largely been driven by patient advocates and their families. I think PWS-specific social services, for example, PWS-specific residential care centres, are now provided and is seen as integral to care in some countries, but not in very many countries. In terms of how we have used the materials, I will say this is the first year we're relatively new to this. So far, IPSO has sent the materials to its 37 national member associations, and we have focused mostly on social media engagement, which actually has just started. Certainly the materials are on our website. I would hope if you ask me this question this time next year, I would be able to point to a lot more we have done with the materials. But I think the toolkit provides an excellent means for people to start a campaign without having, for small groups that do not have the ability or time or money to develop materials themselves, I think they are an excellent starting point for them. And I too think I have just used my time, so I'll hand it back to you, Durhan. Thank you.
Thank you very much again for a very, very comprehensive, but also very clear presentation. And I think we all appreciate the fact that this is the beginning of what we say as the journey and the opportunities. But I love the way in which you kind of been able to frame, how you're out not only sharing them, but where you see the applicability can be even enlarged. So that was excellent. Thank you very much. I don't know, Tony, if you want to add anything else to that.
I think the only thing I'll add is just to go back on the example of growth hormone for people with Prader-Willi syndrome, is that over the years, what's been, I think, our contribution to that has been to make certain the evidence is available and that we can make that evidence available to our membership or to a family or to an organization in another country. And they can then use that to make the case for approval of growth hormone in this case. But I think one of the dilemmas that we sometimes face is that the standards we are held to in terms of evidence are often the standards that are expected for common disorders. And of course, it may be harder to reach those standards of evidence for rare disorders because it's harder to do that level of research or placebo-controlled trials or whatever. But I do think that organizations such as IPSO have a really important role there in getting the evidence and supporting that advocacy process in different countries. And that I'm sure is true for any rare disorder.
That's absolutely brilliant. And maybe if you don't mind, I'll just extend that little conversation a little bit because as you say, having the evidence is certainly important. And then when you think about something like growth hormone, for Prader-Willi, which is actually it's an old common generic, drug now. And we're talking about major expenses. And sometimes I think the call for evidence is a bit of a bit of a smokescreen. You don't need more evidence. You've got evidence in terms of 20 years of successful use. You've got clinicians who have made it into best practice guidelines. And, and we're not going to go backwards to do what controlled, randomized controlled trials. And I think sometimes it's having that advocacy around you to be able to make the case that if we've got growth hormone therapy for common conditions and for kids that are, in some respects, even less, severely affected than the children with specific conditions, then this is a matter of a right. So I think it's really important to make sure that, we don't get put off because it's convenient for those that are in those positions to do so. So really appreciate the campaign and really the way in which I think you've seen, the not only the medications, but the other kind of services, have been able to be advanced because, and I think it's what somebody else also said, it's not just the medication, it's all the other kinds of services. It's all the other, Jan was saying in the beginning, right? So what about the other kinds of supports that are necessary in terms of both the psychological, but also the kind of specific foods, et cetera. So appreciate very much what you're saying. Okay, Claire, we have other questions, or do we want to open it up in terms of a broader discussion here?
Any sort of questions, of course, are welcome. For now, there's none in the Q&A chat, but there was a question that came about Rare Disease Day and maybe how to link this campaign on UHC to also the priority within Rare Disease Day. So if anyone in the panel would like to comment on that, and of course any other topic that we've been covering throughout the webinar. Maybe, I don't know, Jan or Flaminia, anyone?
I have to say that it's one of the advantages of being online is that there is such a rich conversation in the chat that a lot is being said and answered in parallel.
Maybe
if I may comment very briefly on the link between universal health coverage and Rare Disease Day. I mean, what for me the common feature, really the striking common feature, is clearly equity. I mean, there can be no equity if the needs of rare disease patients are not covered, if, as Clara was mentioning, the three main elements of universal health coverage, the population of rare disease patients that are covered, the services related to the needs of patients living with rare diseases are not covered, and if the out-of-pocket expenses are not decreased. So clearly, in a way, it's an essential feature of equity to have this universal health coverage. So for me, the link is clearly around these key concepts, which also go towards the leave no one behind, right? So it also includes the SDGs. So there is really a coherence of all these common goals.
Flaminia, the operative word that you use, of course, is equity, right? It's not equal, it's equitable. And it's equitable meaning, we provide based on the needs. But even in terms of evidence, what Tony's saying, we provide the evidence based on the community. It's not the same evidence, it's not the same level of evidence, but it is based on what the condition, what the population is. So equity is really what we're fighting for, and it may cost more on a per person basis, but I think, and it may be more difficult to reach, I think, as Marguerite was saying, but in order to be equitable, it really has to go to what are we trying to do, and that is make sure that everyone is in fact included. So I think, the more we kind of go over some of these, these concepts, right, and make them from less of a concept to what's a real principle and what's something we need to put into practice. So that's great. Other comments that people may have based on what you've heard, based on your own experiences in using the toolkit, or your aspirations hearing this in terms of using the toolkits, that would actually be good, or even your fears in terms of, I would like to use it, but I don't know that, I can, or it's going to help me that much. I think that would be excellent. Or as Clara says, any thoughts about how you might wrap this into Rare Disease Day for next year?
Dirhan, I just also wanted to remind the attendees that they can Can everyone hear me? I also wanted to remind the attendees that they can use the raise their hands function if they want us to hear their voice and address your questions. Feel free.
Yes. Some people are not as comfortable just jumping in, so.
Exactly, don't.
So maybe I think the suggestion would be that to move forward in terms of stimulating more thoughts or people to think about other questions or conversation starters you would like. That suggestion is that we might move directly into the video, and that will help us open up some other kinds of lines of conversation. So that makes great sense. So should we do that, Kalani, just move into the video?
Yes, perfect.
Happy UHC Day to all. Dear Jan, colleagues from RDI and Eurodis, dear colleagues and friends, the goal of universal health coverage cannot be achieved without addressing the needs of the 350 million people and their family carers that suffer from one of the 7,000 rare diseases worldwide. The word universal says it all. It means that health services are available, accessible, affordable, and of good quality for everyone. Not only for some, and not with delays that cause damage, and not for a price that impoverishes the patients and their families. I want to commend you for bringing rare diseases to the UHC discussion, as this will be a litmus test for UHC. Will we be able to translate the laudable claim of the SDGs, leaving no one behind, into concrete action? Will we be able to join forces across countries, normal boundaries of purchasers and providers, across health financing facilities, so that people with rare diseases can get help, no matter where they are and live, how rich they are, and what their insurance plans say? Will we be able to cluster human and financial resources to address the low incidence of single diseases and advance knowledge when it comes to early diagnosis, cutting-edge treatment, rehabilitation and palliation? Will we be able to establish true global centers of excellence for specific disease clusters that are able to provide assistance to medical and social services worldwide? In essence, will we make solidarity a reality? Colleagues, friends, you have discussed this over the past hours and touched on many of the pertinent issues at hand. Let's get concrete. Universal health coverage is a concrete and achievable goal. It is a realistic option for the world. This means that we need to advance the action on all fronts. What is the lesson for the world from this current pandemic, if not that we can only survive if we build resilient health systems and address the root causes of ill health for humans and the planet? That we need health systems that are there when people need them. Systems that are not overburdened because of preventable diseases caused by the tobacco, alcohol, or sugar or fossil fuel industries. Systems that are enabled to detect future risks for pandemics which lie by far in the design and remit of other sectors. Systems that are then freed up to do the necessary and care for those with non-preventable disease. Many of those are rare. Many of you are affected. Many of you need this global solidarity. Let me assure you, WHO is on your side. I'm so happy that we are twinning up with you to establish this global network of centers of excellence. There is a lot to do. You have provided a clear project plan with realistic deliverables. We take our share. I'm sure that others will join once they see the tangible results of our work. Let's get it done. I thank you.
All right, that was very powerful on lots of different levels. It's one thing to have WHO endorse what we're doing in rare diseases. And I still remember, Jan, the first time we had, Rudiger make the comment of leave no one behind with rare diseases. And we were over the moon because he just even just made the statement. And now he's come out as not only a strong advocate, but he's fully embraced the importance of having rare diseases solidly included in any programs around universal health coverage and health services. So this is a huge, huge opportunity, definitely for us. And I think he's given us the challenge, but also has committed, WHO to working with us. The very notion that he called it a twinning, I think is pretty amazing. RDI being twinned with WHO is kind of a daunting vision, but that's what it is. So this is our opportunity to move forward and make that happen. And Jan, I'm not sure even you had that as the big vision when you reached out and made the connections. Though even you always dream in Technicolor. Maybe
twinning
just
the zebra fish with the twinning the zebra fish with the with the I'm not sure.
Maybe just to get the conversation going, I know we have some comments and questions coming in. Maybe, Jan, if you would just give us the 1 or 2 minute elevator speech around the collaborative global networks. I mean, I'm sure most people hopefully have heard it, but just to kind of bring it back into focus, because he put it into the ending without expanding on it. And it is really worthwhile for us to think about how this fits in with UHC and with rare diseases.
So the ambition is to identify around the world major hospital centers which have competences in some rare diseases, multidisciplinary competences, and which are ready to commit over the years to build on these competences to develop centers for persons living with rare disease and progressively to expand the scope of rare disease they cover in their hospital. We're aiming to attract major hospitals who are paired with research centers, research capacities, and university to have education capacity of the doctors and other healthcare professionals, so that over time we can trickle down in the system. We call them in this vision the hubs, the national hubs, and the hub has a role locally in the major cities where they are located, but also a role at the national level, sometimes at the regional level with other countries which may not have such capacity. And we have a vision of a global network which will be organized by region, 6 regions of the WHO in the world. And all these hubs coming together, then forming this global network to share existing knowledge in terms of best practice of care, in terms of getting a second opinion or a first opinion, even sometimes from the experts in the networks in other parts. And also a network which will share some common features in terms of standards and sharing of data and samples and etc. So a network which also enabled to reach out to patients to do research, particularly for the rarest diseases. So our vision overall is that this identification and this function is first on diagnostic. So it's really to start with diagnosis as the entry to everything anyhow, and to concentrate on the capacity and the commitment of these hospitals, these hubs, to get accredited for these functions with a long-term commitment to diagnostic and to developing this multidisciplinary care. So that's the idea. So there is the local hubs and there is the global network with the give and take between them and of the network to each of the hubs. So I see them as lighthouses, along the coast, where you close or far from the lights, but you connect to the light to navigate on your sea, and that could be that, or lighthouses around the world to help patients to navigate, even though they may be far from the coast.
Very interesting analogy at the end of it, but we will accept that. But I think
That's because maybe you don't navigate that much.
I don't know. It was a very interesting analogy. We understood sort of what you're saying there. I had the vision of almost out there in these little rowboats, kind of looking for the beacon that was out there and hoping that we could get to shore. But I'm sure that is the case. But as you say, it is a powerful concept, right?
Yeah, and it comes with the technology. Is that all this vision is also very much linked to the new technologies in genetic and biology in general, but digital technology, and which enables to empower the people to find their way or to identify that there is something wrong, but also all the possibilities of telemedicine, of clinical boards with experts from different countries, of sharing patients' files, etc. So all these new capacities, which are starting to be available and ahead of us.
If I may add something, is that one of the key features of this global network is that it will focus on patient needs. I mean, that is why the WHO partnered with RDI to develop the concept to set up this global network, is that because it has the intention to start from the patient needs and the patient's perspective and the patient vision, integrating from the very beginning of the development the interface of how to interact with the other stakeholders. So of course, national authorities, other existing networks, industry, etc., all the people that have a role in the rare disease community at large.
Thank you very much, Flamini. I don't know, Flamini, if we ever quite introduce you. I mean, I'm sure most of the people here know you, but there may have been other people from a global community that came on. But just briefly, if you don't mind, Flamini, because we're very proud of you. We want everybody to know who you are.
Okay, so I'm the executive director of RDI since some months now, since last summer. Thank you.
Thank you very, very much. And we're delighted to have Flamini here. She means last summer, this past summer. She doesn't mean like the last summer. So it's only been a few months, but it seems like it's been forever. So really very much a wonderful asset to the RDI, not only just to the staff, but to the community. Thank you very much. So that's, yeah, I just want to make sure everybody knew who Flamini was in terms of her work and her contributions. But there's been some other kind of really important comments that have come forth as well. Clara, maybe you would like to pick up on some here. Yes.
Thank you for everyone for your comments in the chat. First, a few things that we are noting for RDI is there was a demand for, and something that has already been mentioned, to maybe trainings on advocacy. So it's definitely something that we need to think about and maybe incorporate in our work, because some people are saying that there are new groups and they are not sure they are doing the right thing. So I think this is definitely something to consider. Then there was also really good comments on data collection, actually, how one of the barriers may be around that. And it was a comment from Salome, and she was asking, there are other groups that are collecting data or that have developed registries, as David explained they were doing in Mexico. And this is something that could be very important. So if anyone has experiences they want to share, please also go ahead. There was also a comment from, just to tell you that Jan unfortunately needs to leave, but he was very happy to be in the webinar with you all. Let's see whether there was something in the Q&A.
There was something very early on that I don't want to lose. Clara, and maybe we can bring that back in. I think Patricia brought it up first, Patricia Loki, and that is, you know, as much as we're really talking about, you know, having countries endorse, you know, universal health coverage, and you know, the question was who's bought in. Well, the answer is if you belong to the UN, then you're automatically bought in. But on the reality, in terms of on the ground, that as much as we put some of these, you know, initiatives in place, and even when you get endorsements, that we cannot neglect the fact that in many countries we still have to deal with corruption and political interests, and these can actually, and I'm sure that you know, many, you know, people would be able to share that as a common concern. So I don't know if anybody would want to, you know, address it. not to call any one specific country out, but we do know that these are realities, and we certainly know these are realities when we start to talk about implementing programs like, diagnosis or bringing in, treatments. That in many cases you run across not only, regulatory and clinical kinds of barriers, but you do run into the absolutely political and other kinds of, genuine, barriers of craft corruption. So don't know if somebody would like to talk a bit about, the realities of that as we're talking about the possibilities of using these kinds of global initiatives.
Anyone? No.
Patricia, if you're still on, maybe you wouldn't mind just sort of addressing that, because I know I've heard you in other settings and raise it as well. I don't know, Patricia's online?
Yeah, I am online. Thank you.
Okay, if you don't mind.
Okay, thank you. The reason I raise up this issue is because I do believe that when we are within an international organization or international organization, we can claim some rights, and trying. We are not going to expose political problems or even corruption problems, because those are addressed by other instances. But we do need to work with that. And I do believe that if we work it together, it will be easier for the national organizations, for the national federations to work it on, and to, how can I say, and to put on the table how can I say, these problems or our situation. Because if not, what happens is that most of the things that people are talking about will be political problems, corruption problems, and specifically we are now facing problems because of the particular how can I say, a structure we are living in. And that structure means that when we want to advocate, we have to face the barrier of someone trying to get some commission or trying to get some kind of benefit from what we are advocating. So this is something that we are living with, and we are trying to work with too. And on the other side, in the case, I will talk specifically in the case of countries that usually depend on the health system. The health system depends on international cooperation, like European cooperation, USAID cooperation, and it looks like this kind of activities are more focused on generous things, or when they are talking about our problems, they prefer to oversight this situation.
Okay, thank you very much, Patricia. And I think, as you say, we need to kind of take into consideration these realities, when we're talking about the kinds of advocacies that we might be doing. Flamini, I think you wanted to address, sorry, Claire, I know you were trying to host this, I was just jumping around. I think there was a very interesting question that was raised by Robert Thompson with regard to, access to medicines and the challenges, a little bit, not exactly what Patricia was saying, but also related to the fact that in many cases, there are lots of barriers in terms of getting access. So I think you wanted to address that maybe?
Yes, well, I mean, the problem is that with this collaborative global network, we are trying to put together all the experts and the clinical leads at the level, of course, of the hospitals, taking the patient's perspective and how can these centers, these experts, and the overall expertise that exist can support and address the needs of patients. The major stakeholder that is often missing in this discussion, and where we have in the end a bottleneck, are of course the pharmaceutical industry, the pharma companies, and overall the industry sector, because of course there are the medicines, but there are also medical devices and all the rest. So I think that if we take them on board and we decide from the very beginning how we're going to interact with them, then we might, have, how can I put it? We might have a more constructive dialogue with them. Then the national authorities and the payers, of course, they are the end bottleneck, and we're trying to take them on board as well in this global network. As far as we can do now, it's to have the broader dialogue as possible. But there are many ways that we can try to address the access issues, and certainly having this overall dialogue with taking the starting point of the existing expertise and the existing experts and centers where they are could be one of them. This is difficult to address. The access issues are the most difficult to address, and they go down to the national level. And yes.
But they're critical to address. And I think I heard that last night as well when we were doing the symposium with Malaysia. At the end of the day, if you do everything, but you can't get access to the therapies, then of course it doesn't really benefit the patients. And we heard the opposite side of it, and that is where companies have come in and they've set up centers. They do train the clinicians and the healthcare professionals to do the diagnosis. They bring in the therapeutics, sometimes at no cost or at very, substantially reduced costs. And then they also help to, as we say, support the patient group. So we have great models in terms of how, as you say, this can work very well hand in hand. But I think that's another reality that we have to take into consideration, that many of these medicines are in fact very high price, even for patients in very high income countries and very well developed health systems. But they become almost impossible if they were brought in at that same level. So I think one of the things I would just say very quickly is that RDI, along with URDIC, our International Research Consortium on Rare Diseases, we have created a working group and hopefully a task force to really address, as we say, the global access to medicines, because we all agree that equitable access to medicines has got to be part of the agenda. But as Flaminia and everybody else would know, there are no easy answers to this, but they have got to be answers that come in partnership with the pharmaceutical industry, not separate from the pharmaceutical industry. But it may take, as we say, these global initiatives, including us now, to be part of that solution to drive towards that. So it is something I think we, like political interests and corruption, have to take into consideration is very much a part of the real fabric.
Yeah, I think companies are starting to understand that they need to be, as you were saying, Doreen, more creative, that they cannot have like the old model applying everywhere in the world. So they are developing some new pay for performance or other innovative schemes for access, and they are trying to set up some compassionate use programs, and they are starting, and I think we are the right interlocutors for them.
I'm laughing not at you, I'm laughing at Patricia's comment. She says, we have to be careful with the partnerships. We are the clients, not the hostages. So I think it is very easy sometimes to feel like as patients we're held hostage. And we're held hostage sometimes as we get governments or payers warring with companies, and that we are very much in the middle there. We cannot be that. We have to be very much a part of the solution and to really bring ourselves. I think sometimes that's why we have to, I feel like sometimes we have to set the table. Sometimes these discussions take place without us unless we're there to actually set the table and to sometimes bring forth the rules, etc. So I think these collaborative global networks, as Jan talks about, it's an opening again for us to come to the table with solutions, not to say we have problems, not to say we have needs and we need you to solve them for us. That is not the approach. The approach has got to be we recognize it, and we need to bring forth some of those solutions and to, bring the other players to us in terms of being able to solve them, so that, we talk about the empowered patient, and I go back to the advocacy. Sometimes the advocacy isn't so much, can I train you to go in and talk to your governments, but can we set a table where we bring you and your governments together, and we bring together collectively governments where they can learn and hear from each other. That's the power of what we can do, I think, with the WHO or with other entities. As I said, my experience over this past few months with APEC has been stunning in terms of being able to set the table, to bring together the governments, to bring together industry, who are very much interested from a commercial point of view. But now that we've got the opportunity to have patients at the table as well, which is something we fought for. When they first began to talk about, a rare disease framework or within APEC, they had no idea in terms of how to bring patients in. And we, I think as others have said, we persisted and we kept coming in with solutions for them as well. So we're very, very pleased with that. Okay. I will stop and maybe we can have some other questions that may be here.
I think we are reaching the end of the webinar. So we've covered all the questions that were in the Q&A. And as we said before, do not hesitate to send us by email any pending questions. And this is a conversation that is starting and we want to continue with everyone. So thank you for attending. And maybe Duran, you want to say a few last words to close? Or
well, absolutely. Would love to not only thank everybody for attending and for their huge participation, certainly to all the panelists who really took on the task of answering some very difficult questions. It is only the first anniversary of our universal health coverage. So we have done a great deal. Huge kudos, obviously, to Clara for having brought us so far. I'm a huge, huge fan in terms of not only the advocacy work that you do, but the really practical work that you do. And we are thrilled so much to have Flaminia Khawani in our offices to be able to lead this. These are the kinds of things that, I think as part of RDI really can make a huge contribution to the community. We appreciate the comments that people have made. Certainly there is a follow-up if you would like to, reach out to anybody, individually or to certainly into our office. We're really happy to follow up with you. Really, we do know that, RDI is not a few of us here. RDI is really this community, and it's absolutely empowering every time we do these to know that there's such a community. Now I have to run because I have to go do another webinar. Okay, thanks a lot, folks. Bye-bye.
Great. Thank you, everybody. Goodbye.